Good morning. Today we'll be talking about chapter 23 on nursing management of peripheral vascular disorders. My name is Vivian, and my group mates are Melanie, Priscilla R., Chris, and Alan. Moving on to the next slide. So today we'll be talking about a number of things that will include risk factors, manifestations, assessment, nursing interventions, and some possible surgical complications that might occur, if applicable, on the following peripheral vascular disorders and procedures. They will include coronary artery disease, angina pectoris, myocardial infarction, percutaneous coronary intervention, and coronary artery bypass graft.
Hello, my name is Priscilla. My topic is coronary artery disease. Coronary artery disease is one of the most common heart illnesses in older adults. A few common risks include both non-modifiable, which are ones we can't change, which include age, gender, and family history. And there's modifiable ones, which include tobacco use, obesity, and physical activity, which are among others. Some manifestations include ischemia, angina, and cardiac death, but there are those lucky 15% of men who are asymptomatic to any coronary problems and have no idea the damage is being done to their heart. Next slide. Here's a funny meme by Vivian. It says, Jesus watching you intake a large pizza with a 2-liter Coke with your family history of coronary artery disease, hypertension, and diabetes. CAT assessments include patient history, which includes pretty much your family history and then your signs and symptoms of manifestation, and also the location and characteristics of the pain. Some nursing interventions are pretty basic, treating the angina with MONA, which is morphine, oxygen, nitrogen, and ACE inhibitors, and to reduce anything that would stress and or agitate the heart.
Angina pectoris is a type of chest pain caused by reduced blood flow to the heart. Not enough blood equals not enough oxygen. Some risk factors can include atherosclerotic disease, which can be like physical exertion, exposure to cold, which causes vasoconstriction and elevated blood pressure, eating heavy meals, stress, or any emotional provoking situation. Manifestations can include symptoms from mild indigestion to a choking or heavy sensation in the upper chest. Severity can range from discomfort to agonizing pain. Pain may be accompanied by severe apprehension and feeling of impending death. It's often felt deep in the chest, behind the sternum. It may radiate from the neck, jaw, shoulders, and inner aspect of the upper arms, usually the left arm. There can be tightness or heavy choking or strangling sensation. Angina usually subsides with rest and administration of nitroglycerin. Diabetics may not have severe pain with angina due to autonomic neuropathy, which dulls the perception of pain. Older adults may not experience typical pain due to diminished pain transmission that can occur with aging. Assessments would include getting the patient's history related to the clinical manifestations of ischemia, assessing the patient's symptoms and their activity, assess the risk factors, understanding of their diagnosis and current treatment plan compliance. They could also do a 12-lead electrocardiogram showing changes indicative of ischemia, which would include T-wave inversion, ST segment elevation, or development of an abnormal Q-wave. Lab tests would be cardiac biomarker testing, exercise or pharmacologic stress tests, nuclear scan or invasive procedures such as cardiac catheterization or coronary angiography. Nursing interventions would be pharmacologic therapy such as nitrates, beta blockers, calcium channel blockers, antiplatelets, or anticoagulants. You can also do oxygen therapy, activity rest as tolerated, and then you want to make sure you educate the patient on the diagnosis, how to prevent and how to treat, and make sure they also understand the benefits versus risks of compliance and non-compliance to the treatment. That's it. Oh, and then, sorry, just a little something where it's like, no, I said I've got an acute angina. Oh boy, I think I'm gonna get lucky tonight.
Look, you only have one heart, and if that gets occluded by plaque, That leads to ischemia and necrosis of the heart. Today, we're going to talk about myocardial infarctions. Y'all ready? Let's go. His palms are sweaty, knees weak, arms are heavy, dying from them. I don't think I'm ready. Am I having a heart attack? I got pain in my chest with no relief by meds or even rest. Now, how did it start? It came all of a sudden. I was chilling on my couch, watching TV, doing nothing. If my memory is right, my mother had told Dad died of a heart attack at 40 years old. This is my family medical history, coronary artery disease. These are the signs when I'm having an MI, so seek treatment fast or you might die. It's a feeling of pressure or even tightness, a squeezing around your chest, maybe feeling heaviness. Another major sign is shortness of breath. That alone, if not treated, can lead to your death. Some people say that they think it's indigestion, but all actuality, that's a manifestation. You may have anxiety and nausea, heart beating really fast, that's tachycardia. Visually, you'll see that this person is sick. They'll look really pale and diaphoretic. Upon assessment, you'll do 4 things: a patient history and an EKG. A 12 lead, it gives you information, T wave inversion or ST elevation. If that test is non-diagnostic, an echo is needed. Check your kinetics. Last assessment, lab test like troponin, CKMB, and myoglobin. The mnemonic Mona is part of the plan. You got morphine, oxygen, nitro, and aspirin. To the cath lab is your emergent intervention. You'll get a thrombolytic if PCI is not an option. Cardiac rehab is your method inpatient. The goal here is to make you self-sufficient. 1 is education, phase 2 is PT, phase 3 is maintain cardiac stability. These are the things to know about cardiac arrest. My rap is over. I wish y'all the best.
I'm going to do my presentation on percutaneous coronary intervention. So it's a non-surgical procedure used to treat the narrowing of the coronary artery of the heart. The goal is to reduce anginal symptoms, reduce mortality rate from a heart attack, and also reduce the amount of tissue that is permanently damaged by the heart attack, i.e. myocardial infarction, myocardial ischemia. The procedure is going to be done by local anesthesia. You want to educate your patient on the risk factors and then get consent. Risk factors would include damaging heart blood vessels. They could have blood clots, stroke. They can have a reaction to the iodine, and they can also die from the procedure. After you educate them, they're going to be taken to a surgical room where the provider is going to access the femoral artery, insert a guide catheter. This guide catheter will monitor cardiac output and blood oximetry. The provider will also have access to fluoroscopic imaging, X-ray, electrocardiograms, and then the hemodynamic data from the guide catheter. Once that guide catheter passes stenosis, that will go ahead and use that guide catheter to put in a balloon or stent. Nursing considerations: you want to look for signs and symptoms of ischemia and hemodynamic instability. You want to encourage the patient to gradually increase mobility after the procedure and advise them to seek medical attention if the access site starts bleeding or if they have chest pain or shortness of breath. After the procedure, you want them to have follow-up care. You also want to encourage them about lifestyle changes like exercise, diet, and continuing their medication as prescribed. I'm going to show a video on the procedure. It goes past it. So that's the balloon. They can use a stent too. So that's the stent right there. Let me just play it for you. So that's the stent there. So yeah, that's the procedure. If you have any questions, reach out to me. Thanks.
So the next surgical procedure we're going to talk about is the coronary artery bypass graft, also abbreviated as CABG. It's a surgical procedure which involves an occluded artery, coronary artery to be specific, and you have to graft on, let's say, a healthy patent internal thoracic artery from your chest, or maybe a greater saphenous vein from your leg. And that basically reroutes the blood flow around the occlusion. Okay, so very much like the rerouting image over here or the Google Maps pic, when there's a blocked path, you're going to go around it, you being blood circulation. Okay, the surgeon will pick one of two routes if he does do a CABG on a patient. There's a traditional CABG, which includes a cardiopulmonary bypass machine and heparin, and the other route uses an off-pump coronary artery bypass method, along with beta blockers and a stabilization device. Let's go on to the next slide. So as you can appreciate from the figure in the book, figure 23-9, this shows the heart, okay? And on the left and right side, there are some blockages, some occlusions on the coronary arteries. The left side of the image shows the saphenous vein graft, which reroutes the blood. And also on the right side over here, the internal mammary artery graft, also known as the internal thoracic artery, okay? Going on to the next slide. So to be recommended for CABG, the surgeon would have to consider a number of factors for the patients that include how diseased your coronary vessels are, how dysfunctional your left ventricle is, and also the degree of the occlusion for your coronary arteries. Other things to consider would be if the patient has a history of like angina or left main coronary artery stenosis, or had developed complications from PCI, and those treatments were unsuccessful, the patient will be considered for CABG. Next. Okay, so in terms of assessment, we would have to do a physical assessment on the patient, look at their clinical history. The main age group for CABG would be gero patients, senior patients. They also tend to have comorbidities with them too. They might be diabetic, they might be hypertensive, they might have, a decreased left ventricle function. And we have to look into if they have any past surgical histories too, like cardiovascular surgeries or maybe PCI, and check if they're at risk for strokes or myocardial infarctions. We'll be running a bunch of tests too, like chest x-ray, ECG, lab tests, and blood work, just to rule out any abnormalities or things to take into consideration, along with checking the integrity of the valves and vessels. Okay, we'll also be looking into the patients and the families' like educational needs, see what coping mechanisms are successful, along with support systems, which will be taken into consideration for their discharge plans and rehabilitation. Possible complications that can occur, you can refer to the book in table 23-4. It'll list everything out for you. But ABCs could be affected. That includes bleeding, that includes impaired gas exchange, fluid overload, heart failure, numerous many things. So because of that, for nursing interventions, we have to assess the patient for disorders that can complicate their post-operative recovery, like diabetes, hypertension, and lung disease. They might be on medications like aspirin, beta blockers, statins, coagulants, anti-hypertensive meds, and diabetic medications. When it comes to care, patients need to be bathed in an antiseptic solution, and they're going to have to apply mupirocin calcium 2% ointment in each nostril to prevent any infection of the surgical site on the chest. Okay, we'll be promoting patients to do respiratory care like deep breathe and cough instead of spirometer, and also ambulate. We'll also be doing like pain management, wound care, and infection control, also tracking the progress of their activity and giving them proper nutrition for their recovery. We also need to educate patients on their medications and modifiable risk factors. And every 4 hours, we'll be doing a complete systems assessment that will involve neuro, cardio, respiratory, peripheral vascular, renal, and pain status checks. Okay, and that concludes the end of our presentation. Thank you very much.